when my patients are really, really inflamed, that is really beneficial to have them start doing is exercising, because we're getting an anti-inflammatory effect that's a guiding, not a forcing. I could give them an NSAID that's anti-inflammatory, but it's not going to give me the same effect. We know that, but why, right? These are the big things that I tend to talk to my patients about, with probably the most important one being the anti-inflammatory myokines. So a myokine is just going to be, it's like your IL-10, TNF-alpha. It's a molecule that is going to be secreted from muscles. Cytokine is generalized. Adipokine means it comes from adipose tissue. Myokine means it comes from muscle, okay? The super, super interesting thing is that, for example, IL-6 is an anti-inflammatory myokine, but a pro-inflammatory cytokine. And I should rather say a pro-inflammatory adipokine, meaning that when the adipose tissue secretes IL-6, it has an inflammatory effect in the body. When muscle secretes IL-6, it has an anti-inflammatory effect in the body. Super crazy. It also makes research super confusing to read sometimes. So that's one of the big things that when my patients are really, really inflamed, that is really beneficial to have them start doing is exercising, because we're getting an anti-inflammatory effect that's a guiding, not a forcing. I could give them an NSAID that's anti-inflammatory, but it's not going to give me the same effect as having them get the anti-inflammatory effect from exercise. Mechanical force, obviously we are strengthening tissues that are degenerative, okay? This is the physical therapy realm, and why I love physical therapy so much and truly believe that it is underutilized in the regenerative injection space. I don't know why, but a lot of docs just inject and say, see you in 6 weeks, or they're working on the other stuff as well. 90% of my patients are getting a physical therapy referral. Okay? The one thing that I think needs to improve is discussions between docs who do regen injections and the physical therapists to better understand how to approach these patients who have just had PRP or stem cells, because it's different than an acute injury, it's different than surgery, it's different than a chronic injury. It's a chronic injury that we've introduced an acute injury into, more or less. And so I think there's going to be a big boom in the physical therapy world over the next 10 to 15 years on physical therapists who specialize in recovery from stem cell procedures, PRP procedures, and things like that, because it's different. Similar, but different. Obviously, with exercise, we're going to improve our comorbidities, diabetes, hypertension, even hyperinsulinemia, things like that. We're going to get some improvement in hormones, which, if you actually kind of read the research, is slightly mixed in terms of, whether strength training actually truly increases testosterone levels, for example. There's actually some research suggesting that it might not. But I still think, again, with exercise, we are getting a better utilization of our hormones. We can start to see differences in expression of receptors in our hormones, which is going to be more important than the actual levels of hormones. I don't care if your testosterone levels go up. What I do care about is, are your cells responding to that testosterone better? Because at the end of the day, that's what matters, that the nuclear receptor is being hit sufficiently by the testosterone, not that you have more of it floating in your blood. And then improvement of blood flow. Where there's blood flow, there's healing, right? And so especially in our tissues that are already avascular, like the cartilage, or it's very little vascularization, tendons, ligaments, things like that, the more blood flow we can get into an area, the better things are going to heal.